Your doctor ordered a test today that has a 40% chance of coming back wrong. Not because they made a mistake, not because they're a bad doctor, but because that is what the data shows about this test in people your age. Did they tell you that before they ordered it? Because what happens after a false result is not nothing. It is a scan, then a biopsy, then a procedure. And that procedure carries its own risks. Risks that land very differently on a body over 70 than they did at 55. I'm Dr. Victor Kane, and this is the conversation no one is having until something goes wrong. Stay with me. Before we get into this, drop your name and where you're watching from in the comments right now. I read every single one. This community is bigger than I ever expected, and I genuinely want to know who's here today. All right, let's get into it. The 70 threshold. Why everything changes. Before I walk you through the 5 checkups, I need to give you one idea, one frame. Because without it, what I'm about to say might sound like I'm telling you to avoid doctors. I'm not. What I'm telling you is something far more specific than that. There is a threshold, and for most people, that threshold is somewhere around the age of 70. Before that threshold, routine screening medicine operates on a simple and largely reliable logic. Find problems early, treat them early, live longer and better. That logic works. It has saved enormous numbers of lives. I believe in it completely, for the right person at the right time. But after you cross the 70 threshold, 3 things shift in ways that most standard medical appointments never account for. The first shift. Your body is no longer the same partner in recovery that it once was. A procedure that a 58-year-old moves through in 2 weeks can take a 76-year-old 3 months, with complications along the way that compound, that interact with other conditions, that ask more than the body has left to give. The intervention itself becomes a risk factor. The second shift. The conditions most likely to be found by routine screening in someone your age are very often conditions you would have lived alongside without ever knowing they were there. Slow-moving, silent, never destined to cause you a single symptom. But once a report names them, the system is not built to leave them alone. It is built to treat them. And treatment, in a body past the 70 threshold, carries weight it didn't carry before. The third shift, and this one matters most. There is a momentum to medical care that most patients don't realize they've stepped into until they're already moving. One result triggers a follow-up. That follow-up recommends a procedure. The procedure has a complication. The complication requires its own management. And now you are deep inside a system responding to a problem that may have never needed to be found in the first place. I call this the downstream effect, and it begins, almost always, with a single routine test. Keep the 70 threshold in mind as we go through each one. It will make everything clearer. Checkup number 1. Routine PSA testing in men over 75 with no symptoms. I want to start here, because this is the one men almost never push back on. It feels responsible. It feels like the kind of thing a man who takes his health seriously does every year without question. You go in, they draw blood, a number comes back. And if that number is elevated, even slightly, even within a range that specialists debate, a chain begins. I had a patient I'll call Eugene, 78 years old, retired civil engineer from a small town in Ohio. The kind of man who fixed things before they broke. Every Saturday morning, without fail, he was in his garage, restoring a 1967 Ford Mustang he'd been working on for 11 years. His wife Carol used to joke that the car would be finished the same year he turned 90. He had 2 grandchildren, a vegetable garden that his neighbors talked about, and not a single complaint about his health. He came in for a routine physical. Felt fine. Slept fine. Moved fine. His PSA came back at 5.1, slightly above the threshold his doctor used. A biopsy was recommended. The biopsy confirmed a low-grade prostate cancer, Gleason score 6, the least aggressive category there is. His urologist presented two options: radiation or surgery. Eugene was an engineer. He liked solving problems permanently. He chose surgery. The surgery itself went smoothly, but the recovery didn't. Incontinence that lasted 14 months. Nerve damage that affected his daily life in ways he had never been clearly warned about. He stopped going to the garage on Saturday mornings. Not because he couldn't, but because the fatigue and the discomfort made the joy of it feel far away. And when we sat together a year later and looked at the pathology, at the growth rate, at everything the data showed, the honest truth was that cancer was almost certainly never going to be what ended Eugene's life. He would have died with it, not from it. He was angry, not at his doctor, who had followed standard protocol correctly, but at the fact that nobody had sat down with him before any of it started and said, "Eugene, at 78, with a Gleason 6, here is what active surveillance looks like. You come in every 6 months. We monitor. We watch. And for most men your age with this exact finding, that is all that ever needs to happen." That conversation didn't happen. The Mustang sat in the garage. And Carol stopped making the joke about the car being finished when he turned 90. The U.S. Preventive Services Task Force recommends that PSA screening decisions in men 70 and older be made on a fully individualized basis, with explicit discussion of the overdiagnosis risk. Because the evidence is clear. In older men, routine PSA screening finds cancers at a rate far exceeding the rate at which those cancers would ever cause harm. What to ask instead? If my PSA is elevated, what is the likelihood, given my age and this specific finding, that this cancer would affect my life in the next 10 years without any treatment at all? And what does active surveillance actually involve? Those two questions belong in the room before any procedure is ever discussed. Checkup number 2. Routine colonoscopy after age 75. Let me tell you about a woman I'll call Ruth, 76 years old, retired high school English teacher from a suburb outside of Nashville. She had been widowed 3 years earlier and had just started to find her footing again. She'd joined a book club. She was planning a trip to Portugal with her daughter in the spring. She was sleeping better. She was, by every measure, doing well. She had clean colonoscopies at 52 and 63. No polyps. No family history of colon cancer. No digestive symptoms of any kind. Her new primary care doctor looked at her chart and said she was due for another one. Ruth didn't question it. She trusted her doctor completely. She scheduled the procedure, picked up the prep kit from the pharmacy, and followed the instructions the night before, drinking the bowel cleansing solution as directed. By 2 in the morning, she was sitting on the edge of her bathtub, dizzy and confused. By 6 in the morning, her daughter, who had stayed over to drive her to the appointment, found her unresponsive on the bathroom floor. They never made it to the procedure. Ruth was admitted to the hospital with severe dehydration and dangerously low sodium levels. Her heart was showing signs of stress. She spent 5 days inpatient. The Portugal trip was canceled. The book club waited. And Ruth, who had been doing so well, who had finally started to feel like herself again, spent the next 2 months rebuilding the strength and confidence that 5 days in a hospital bed had quietly taken from her. She never had the colonoscopy. And based on everything, her history, her risk profile, the evidence, she didn't need it. The U.S. Preventive Services Task Force recommends against routine colonoscopy screening for average-risk adults over the age of 75. After that age, if you have no symptoms, no family history, and clean previous scopes, the procedural risk outweighs the survival benefit in a meaningful and documented way. Bowel perforation, a literal tear in the wall of your colon, occurs in roughly 1 out of every 500 colonoscopies. In a younger patient, that is a serious but manageable surgical complication. In a 76-year-old woman who is still rebuilding after loss, it can mean emergency surgery, weeks of hospitalization, and a recovery that changes the shape of daily life permanently. What to ask instead? Is there a stool-based test, Cologuard or the annual FIT test, that could screen for warning signs without the procedural risk? Non-invasive, no prep, no hospital visit. These tests can identify genuine red flags that would warrant further investigation. And if you have symptoms, blood in your stool, unexplained changes in bowel habits, new abdominal pain, please don't wait. Get evaluated. Symptoms are a completely different conversation. What I'm describing is the routine, symptom-free scope in someone who is otherwise well and whose previous results have been clean. If you're still with me and this is landing, type the number 2 in the comments right now. It tells me you're here, and I read every single one. Checkup number 3. Annual mammography in low-risk women over 75. I want to tell you about a woman I'll call Sylvia, 77 years old, retired pediatric nurse from a mid-sized city in Florida. She had spent 31 years taking care of other people's children. In retirement, she took care of her garden, her 2 cats, and her Thursday afternoon watercolor class at the community center. She had no family history of breast cancer, no genetic markers, no symptoms. She went in for her annual mammogram, as she had every year for the past 2 decades, out of habit. Out of the belief that this was simply what responsible women did. The mammogram flagged a small area of concern. A follow-up ultrasound was ordered. The ultrasound recommended a biopsy. The biopsy came back positive for a small, low-grade, hormone receptor-positive tumor. Slow-growing. Contained. The kind of finding that researchers have a specific term for. Clinically insignificant. But clinically insignificant is not a phrase that appears on the report your surgeon reads. What appears on the report is the word cancer. Sylvia had a lumpectomy, then 6 weeks of radiation. The radiation fatigue hit her harder than anyone had prepared her for. She missed her Thursday watercolor class for 4 months. Her garden went unattended through most of the summer. One of her cats developed a urinary problem during that period, and she didn't have the energy to take him to the vet as quickly as she would have otherwise. These are small things. I know they are small things. But they were her things, and the treatment that took them from her, even temporarily, was for a cancer that the data strongly suggests would never have shortened her life. Studies have found that a substantial proportion of breast cancers detected in women over 75 through routine mammography are clinically insignificant, meaning treatment offered no survival benefit, only side effects. I am not telling you mammography is wrong. I am telling you that after 75, in an average-risk, symptom-free woman, the question is no longer just, could this find something? Almost certainly it could. The question is, if it finds something, is the treatment that follows likely to help me live longer? Or is it more likely to affect my quality of life without changing my outcome? What to ask instead? What is my personal risk profile? And if this mammogram finds something, what does the research say about whether treatment improves survival in someone my age with my health history? That conversation, had before the test, changes everything that comes after. Checkup number 4. Routine cardiac stress testing. Without symptoms. This is the one that surprises people the most, because it sounds like exactly the right thing to do. Let me tell you about a man I'll call Walter, 73 years old. Retired high school football coach from a small town in Georgia. Still walked 3 miles every morning. Still refereed youth league games on weekends. His wife Helen made him go to the doctor every year, whether he wanted to or not. He wanted to. Walter was not the kind of man who ignored his health. His doctor said, "You're 73, you're active, let's just put your heart through a stress test and make sure everything is holding up." Walter liked the idea. He liked data. He liked knowing things were working the way they should. The stress test flagged an abnormality. Not chest pain, not dizziness, not any symptom at all. Just a reading on a monitor that fell outside the expected range. Walter was sent for a cardiac catheterization. The catheterization found a partial blockage in one of his coronary arteries. 40% narrowing. His interventional cardiologist looked at the image and said the responsible thing to do was to place a stent. Walter agreed. He trusted the process. He trusted the people. After the stent, he was placed on dual antiplatelet therapy, 2 blood thinners simultaneously. One of those medications gave him gastrointestinal bleeding 4 months later. He spent 3 days in the hospital. The blood thinners had to be adjusted. His morning walks got shorter because his energy wasn't the same. He stopped refereeing games because the physical demands felt different now. Not impossible, but different in a way that made him cautious in a way he had never been before. And here is what Walter learned, sitting in my office afterward, reading through the research together. The ischemia trial, one of the most rigorous cardiovascular studies of the past decade, found that stenting in patients with stable coronary artery disease and no acute symptoms did not reduce heart attacks or extend life compared to optimal medical therapy alone. Walter's stent did not make him safer than a well-managed medication, and his 3-mile morning walk would have. But it did change his life, and not in the direction anyone intended. What to ask instead? I have no symptoms, no chest pain, no shortness of breath with exertion, no palpitations. What specifically are we hoping to find with this test? And if we find something, what does the evidence say about whether intervention actually improves outcomes in someone my age? Those questions, asked before the treadmill, might have kept Walter on it. Type the number 4 in the comments if you're still here. I want to know who's making it through. Checkup number 5. Asymptomatic carotid artery ultrasound screening. This is the one I feel most responsible to explain clearly, because the gap between what sounds logical and what the evidence actually shows is wider here than almost anywhere else in medicine. Let me tell you about a man I'll call Thomas, 71 years old, retired postal worker from a mid-sized city in Pennsylvania. He had delivered mail in the same neighborhood for 26 years. He knew the names of every dog on his route. In retirement, he volunteered at his church, helped his son renovate a kitchen, and spent Sunday afternoons watching whatever sport was in season. His wife, Margaret, said he was the healthiest person she knew. No neurological symptoms, no history of stroke or mini-stroke, no vision changes, nothing. He went in for a routine physical. His doctor, being thorough, added a carotid artery ultrasound to the order, standard in many practices for patients over 70. The ultrasound found a 72% narrowing in his left carotid artery. His vascular surgeon looked at the image and recommended a carotid endarterectomy, surgery to clean out the blockage and reduce stroke risk. Thomas and Margaret sat in that office and heard the word stroke and made the only decision that felt possible in that moment. Thomas had the surgery on a Wednesday. On Thursday morning, he had a stroke. Not from the blockage that had been sitting quietly in his neck for years, causing no symptoms, bothering no one. from a tiny piece of plaque that dislodged during the procedure and traveled to his brain. Thomas recovered, partially. His left side was affected. He walks with a cane now. He no longer volunteers at the church because the coordination required for some of the physical tasks is beyond what his left hand can reliably do. He watches sports on Sunday afternoons, but he watches them differently now. From a chair he didn't used to need. The U.S. Preventive Services Task Force explicitly recommends against routine carotid artery screening in adults with no neurological symptoms. Their analysis found that in asymptomatic people, the risk of surgical harm outweighs the potential benefit. Here is why. A large proportion of adults over 70 have some degree of carotid narrowing. It is part of normal vascular aging. It has been there for years. It is stable. It is not going to announce itself. And in the vast majority of cases, the overwhelming majority, it never will. But when you screen for it routinely, you find it. And when you find it, the pressure to act is real and immediate and human. Nobody wants to look at a 72% narrowing and say, let's leave it alone. Even when leaving it alone is exactly what the evidence supports. What to do instead? If you have no neurological symptoms, no sudden vision changes, no episodes of facial drooping or arm weakness, no unexplained severe headaches, no brief periods of confusion or difficulty speaking, routine carotid ultrasound is not supported by the evidence. The most powerful stroke prevention tools you have are aggressive blood pressure management, blood sugar control, treatment of atrial fibrillation if present, staying physically active, and not smoking. These interventions have robust evidence behind them. They carry no surgical risk, and they address the actual mechanisms driving stroke in aging adults. If you do experience any of those symptoms, even briefly, even if they resolve completely on their own, do not wait. Get evaluated the same day. What I'm describing as not recommended is the routine screening of people who feel neurologically well. A symptom changes everything. Your protocol for every single appointment. I promised you something practical. Here it is. Before you agree to any screening test, especially after 70, especially when you feel well, I want you to have 5 questions ready. Not to be difficult, not to refuse care, but because these questions are the difference between being a passenger in your own healthcare and being the person who understands what road you're on. Write these down. Put them in your phone. Read them before every appointment. Question 1. What are we actually looking for with this test? And how common is a true positive finding in someone my age with my health history? This grounds the conversation in your specific reality, not a general population statistic. Question 2. What is the false positive rate of this test in people my age, and what happens next if the result comes back positive? This is the question that reveals the downstream effect before it begins. If a positive result leads to an invasive procedure, you need to know that before the test, not after. Question 3. If this test finds something, what are the realistic treatment options for someone my age? And what does the evidence say about whether treatment improves outcomes compared to careful monitoring? This separates finding from fixing. Not everything that can be found should be treated. Not at every age. Not in every body. Question 4. What is the procedural risk of the treatment most likely to follow a positive result? Every intervention carries risk. Eugene's surgery, Ruth's prep, Walter's stent, Thomas's procedure. The risk is real, and it is yours to know before you consent to the test that might lead there. Question 5. What is the most effective thing I can do right now, without any procedure, to address the condition this test is screening for? Because for blood pressure, bone health, heart disease, and stroke risk, The answer to this question is almost always more powerful than most people expect. And it comes without a recovery period. A physician who welcomes these questions is a physician worth keeping. One who dismisses them is telling you something important, not about your health, but about how your care is likely to go. I want to leave you with something I've come to believe deeply after years in this work. Eugene is still in Ohio. The Mustang is still in the garage. Carol still hopes it gets finished someday. Ruth made it to Portugal eventually. A year late, but she made it. She sent me a photograph from Lisbon. She looked like herself again. Walter still walks in the mornings. Shorter now, but he walks. Thomas watches football on Sunday afternoons, from the chair, with Margaret beside him. These are real lives. Real people who walked into routine appointments feeling well and walked out onto roads they never planned to travel. Not because their doctors were negligent, not because the system failed in any obvious way, but because nobody sat down with them before the test, before the referral, before the procedure, and said, "Here is the full picture. Here is what we might find. Here is what happens next if we do. And here is the question only you can answer. Is that a road you want to be on?" You have the right to that conversation. Before the test. Every time. The goal of your healthcare after 70 is not to generate findings. It is to protect the life you are actually living. The morning walks, the book clubs, the watercolor classes, the Mustangs and garages that are still going to get finished. Medicine has extraordinary tools. I believe in those tools. But tools are only valuable when they are used for the right person, at the right time, with the full picture on the table. You deserve the full picture. If this video helped you think about your health differently, subscribe. I'm here every single week with the kind of honest, evidence-based conversation that a 15-minute appointment rarely has room for. And leave a comment below. Have you ever had a routine test lead somewhere you didn't expect? Your story matters here. It might be exactly what someone else needs to read before their next appointment. Take good care of yourself. I'll see you in the next one.